Radiographic interpretation of dental caries. Dental caries, as you all know, it's a multifactorial disease where there is interaction of three factors: tooth, microflora, and diet. Lactic acid produced by bacteria from fermentation of carbohydrates causes dissolution or demineralization of dental hard tissues. Streptococcus mutans plays a major role in the demineralization of enamel. Radiographic examination of dental caries. Lesion seen in radiograph as a radiolucent darker zone. Demineralized area does not absorb as many X-ray photons as the unaffected portion. That's why you see a radiolucent or dark zone in the radiograph where there is the lesion, dental caries or the lesion. Radiography cannot reveal whether the lesion is arrested or active. Only a second radiograph taken at a later time can reveal whether the lesion is active or not. Bite-wing projections is the most useful radiographic examination for radiologic examination for detecting caries. Use of film holders with beam aiming device reduces the number of overlapping contacts and improves the image quality, thus minimizing the interpretation errors. Periapical radiographs useful primarily for detecting changes in the periapical bone. Paralink technique is more valuable in taking periapical radiographs. Size 2 film, adult films used for bite-wing examinations from the age 7 to 8 years onwards. Size 0 may be used in case of small children. Examination with digital imaging. Digital image receptors may replace film for intraoral radiography. There are two methods. Solid-state sensors where you use CCD and CMOs. Either a cord connects the receptor to a computer or without a cord, signal transferred by radio waves, storage phosphor or PSP plates that uses a film-like plate that is processed or scanned after exposure. Problems are there when we use sensors used for bite-wing examination. There is surface area of the film is smaller than the surface area, smaller than size 2 film, stiffness and increased thickness of the sensors causing projection errors and retakes. Radiographic detection of lesions. Proximal surfaces. Shape of the early radiolucent lesion is a triangle with its broad base at the root tooth surface spreading along the enamel rods, but other appearances are common such as notch, dot, band-like or thin line-like. When demineralization front reaches the DEJ, it spreads along the junction forming a second triangle with apex directed towards the pulp chamber. This triangle has wider base than in enamel and progresses forward to the pulp along the direction of the dentinal tubules. Lesions involving proximal surfaces most commonly found in area between the contact point and the free gingival margin. This type of lesion does not start below the gingival margin, helps to distinguish a carious lesion from cervical burnout. Attention should be paid into intact proximal surfaces adjacent to a tooth surface with restoration because it may be damaged during restorative procedure and is at higher risk for caries. False interpretations, you have false positives and negatives. Positives are pits and fissures, cervical burnout, match band effect, hypoplastic pits, concavities produced by wear, which can mimic the appearance of a carious lesion. False negatives are demineralization, not visible radiographically, overlapping contacts in the contact points in images. Half of the proximal lesion in enamel and it cannot be seen radiographically. Occlusal surface carious lesion in children and adolescents most often occur on the occlusal surface of posterior teeth. Demineralization process originates in enamel pits and fissures where bacterial plaque gather. It starts in the sides of a fissure wall rather than at base and tend to penetrate nearly perpendicularly towards the DEJ. Early lesion is like a chalky white, yellow, brown, or black discoloration of occlusal fissures. Such discoloration indicates need for radiographic examination. If the lesion has not crossed the DEJ, it may not be visible in radiographs. Classic radiographic feature of lesions extending to the dentine is a broad-based radiolucent zone beneath a fissure with no changes in the enamel. False interpretations. Superimposition of image of buccal pit with or without associated caries lesion, a composite restoration which may simulate an occlusal lesion, a deep occlusal fissure. False negative outcome may not represent a severe mistake as the process progresses slowly and lesion is detected at a later time. False positive outcome may result in a sound surface being irreversibly damaged. Next one is match band effect. It is an optical illusion. When there is a sharply defined density difference such as between enamel and dentine, they may appear more radiolucent immediately adjacent to enamel. Rampant caries, rapidly progressing caries lesions seen in children with poor dietary and oral hygiene habit, may also seen in people with xerostomia. Radiographs show severe caries destruction, especially of mandibular anterior teeth. Buccal and lingual surface caries occurs in enamel pits and fissures of teeth. When small, they are round. As they enlarge, they become elliptical, semilunar with sharp, well-defined borders. Difficult to distinguish buccal or lingual lesion on a radiograph. Look for uniform non-carious region of enamel surrounding the radiolucency. Well-defined circular area represents parallel non-carious enamel rods surrounding the buccal and palatal lesion. Root surface lesions involve cementum and dentine. It should be detected clinically and most often radiographs not needed for diagnosis. It should be distinguished from cervical burnout in root caries. There is absence of an image of root edge and by the appearance of a diffuse rounded inner border where the tooth substance has been lost. Associated with dental restorations, caries lesion occurring at the margins of an existing restoration which is termed secondary or recurrent caries. Not to confuse with secondary and residual caries. Residual caries remain if the lesion is not completely removed. Two radiographic views should be made in case of multiple radio-opaque restorations. Recurrent lesions at mesiogingival and distogingival margins are frequently detected radiographically. Restorative materials vary in radiographic appearance depending on thickness, density, atomic number, and X-ray beam energy. Older calcium hydroxide liners without barium lead zinc appear radiolucent and may resemble recurrent or residual caries. Composite, plastic, or silicate restorations may also resemble caries lesion. Despite of calcium present in calcium hydroxide, large proportion of low atomic number material in calcium hydroxide causes its radiodensity to be similar to a caries lesion. Therapy after radiation. So radiation caries is a form of rampant caries seen after radiotherapy and it is seen as a radiolucent area at the necks of teeth, especially on the mesial and distal aspects of teeth. Alternative diagnostic tools for detection of dental caries, light fluorescence or QLF, diagnodent laser, that is light fiber optic transillumination or FOTI, ECM or electrical conductance measurements, ultrasonography. QLF helps to quantify the mineral loss on smooth surfaces. Diagnodent and ECM applied on occlusal surfaces. FOTI for proximal surface may also be applied for occlusal surfaces and is less sensitive than radiography for distinguishing shallow and deep lesions. ECM is better than FOTI in identifying occlusal caries in young children.